it's my pleasure to introduce to you Dr. Stephen Powell.
Around 2000 was the beginning of this trend. Almost every new unit that's being built these days is a single patient model. The problem was for us, in the open bay, nurses heavily rely on line of sight to physiological monitoring. And this concept of line of sight to the patient is something that was really fundamental to the way that nurses practice. You needed help, you just yelled, help. We moved to a single patient room. Babies are spread over a much larger area. There's really no line of sight. Alarms can't be heard outside of the patient rooms. The staff are primarily in the rooms. They can't talk to each other the way they used to. And there's just absolutely no awareness of what's going on with the other patients. This is our old NICU, and this is what our new unit looks like. There's all single patient rooms. This is what they look like from the hallway. When we first planned the design, no one really thought about alarm fatigue. And alarm fatigue is overexposure to alarms that can result in ignoring critically important alarms. And this is a fundamental problem we have. What do we do with all of these alarms that are alarming the room that we don't care about or want to know about? Why can't we turn those off? This disconnecting communication and line of sight mitigated primarily with technology. We started off just with physiological monitors, ventilators, and the nurse call system, going to wireless phones that we can successfully make the transition from open bay to single patient environments while maintaining safety and minimizing alarm fatigue. So we wanted to develop a strategy to minimize alarm fatigue because we were aware that that would be a problem. We needed to configure and test the systems as part of the integration, and more specifically to test clinical simulation prior to go live. And I can't stress how important that is. Going into a new unit with new technology, you really need to have a good simulation program. And you need to have a multidisciplinary team. You need to get hospital leadership and executive management on board. That's not something that's easy to do in the days of juggling priorities and budgets. We send out RFPs to 4 companies. They're Connexall, AMCOM, Philips Emergent, and ASCOM. Connexall is the official middleware provider of Draeger, and they have collaborated quite extensively working on this particular interface. So we chose middleware from Connexall primarily because of this Draeger interface in terms of when you look at specific advantages. They had the best integration for nurse call. They were compatible with the handsets we already had with the flexibility to change in the future because that was something we didn't want to take on as part of this project. But we needed to deal with the data aggregator. So as I mentioned before, the Softkeys can allow the cancellation, escalation. This is the TAP protocol. The assignments are entered in the nurse call system, and then they sync directly with Connexall. That way you don't have to sign into 2 systems. The Draeger also speeds all of this data through for the alarms and for critical values. You can put up to 64 monitors on each gateway, and each gateway needs an independent interface. The nice thing here is that the severity of the alarms and the escalation all can be defined. Epic is our master repository for ADT data. That's automatically ported through to Connexall. And then there are these data aggregators that we use. Draeger has 3 levels of acuity in terms of the sound, and we got the ringtones directly from Draeger as well as from Coridian for the ventilators. And then we clipped them down so that they weren't very long, and we made the phones make the same sound that the devices make at the bedside. Just a SQL server, it logs all of the data. There needs to be data retention. We had 13 monitor alerts from Draeger. We had 48 Coridian alerts. We didn't know that none of them were working properly, and that our rolling nurse call system was crashing and rebooting every day, and because nobody was monitoring those things. And with the help of Connexall, we added what they call heartbeat functions. So all of these servers have a little utility that just pings Connexall either every 30 seconds to once every 2 minutes. And as soon as Connexall doesn't hear from those things anymore, it says, wow, there's something wrong, and sends alerts to the appropriate people. We wanted to simulate a bunch of scenarios that were typical of what we do in our unit. What happens when there are 2 babies that are having a crisis at the same time? This is a Connexall report called a heat map, just to kind of show you that when you look at the variability, we had a set of twins that were just desaturating nonstop during that time. This is 18,000 and 22,000 alarms just from those babies over a month, as opposed to other patients where, look, here's one with 200. So you go from 200 to 22,000, even though you can look at what your average is, there are individual patients who may be causing dramatic alarm fatigue, even though the average for your unit is not very high. It was in May, at the end of May, that we made these changes, and so if you look at that, all of the alarms that are going to the phone, those are the ones that we stripped out. And so after May, the number of alarms to the phones went down dramatically to an average of less than 60 alarms per patient per day, so we cut the alarm transmission in half.
Thank you, Dr. Powell.